efforts with TB control strategies. Since tobacco consumption weakens the immune system, making individual more susceptible to TB infection, as such, addressing tobacco use will automatically strengthen our fight against the TB. As we commemorate today World TB Day, let us remember that our collective action matters. Each step we take and each conversation we have contributes to a healthier India and a healthier world. With this, I once again extend a very warm welcome to all the participants, and thank you very much. Over to Dr. Sanchika.
Yeah.
Thank you, Sanchika, for this slide. Now, our first speaker of the day is Dr. Mira Aghi. I don't think I need to introduce her. She's a well-known personality in this field. I'll straight away request Dr. Mira ji to please start with her,
Yes, I am only going to talk about a few pointers just to remind you, because you know all these, and wait for the real seasoned people who work in this area like Dr. Rana and others, and to listen to them very carefully. Now, TB, as we have learned, is an infectious bacterial disease characterized by the growth of nodules in the tissues, especially the lungs. The World Health Organization has reported that smoking causes 9% of all deaths worldwide. TB is a contagious infection that usually attacks the lungs. It can also spread to other parts of the body, like the brain and the spine. Exposure to tobacco smoke has been found to affect TB by increasing the risk of TB infection and the risk of developing TB as the disease. Smoking damages the lungs and impacts the body's immune system, making smokers more susceptible to TB infection. Exposure to secondhand smoke is also significantly associated with TB disease and with TB infection among children and young people. Smoking is associated with recurrent tuberculosis and its related mortality. The risk of developing TB is doubled for people who smoke as well as for those who are exposed to second-hand smoke, that is passive smoking. Furthermore, tobacco smoking slows the recovery from TB and is associated with unfavorable treatment outcomes, including recurrence of TB and death. In addition, the use of smokeless tobacco has also been found to be associated with poor TB treatment outcomes. TB bacteria can live in the body without making you sick. This is called latent TB. This is called latent TB, and we all are familiar with this name. In most people who breathe in TB bacteria and become infected, the body is able to fight the bacteria to stop them from growing. People with latent TB infection have no symptoms. Since not everyone infected with TB bacteria becomes sick, as a result, two TB-related conditions exist: latent TB infection and TB disease. A person with a latent TB infection cannot pass the disease to other people, but in other people, especially people who have a weak immune system, the bacteria become active, multiply, and cause TB disease. People with latent TB have no symptoms, don't feel sick, can't spread TB bacteria to others, usually have a positive TB skin test reaction or positive TB blood test, may develop TB disease if they do not receive treatment for latent TB infection. Active smoking is significantly associated with TB disease and deaths from TB. Up to 1 in 5 deaths from TB could be avoided if patients were not smokers. Smokers with TB need counseling and help with quitting. Advise them to quit tobacco use and avoid exposure to secondhand smoke. This is the warning, this is the instruction we need to give them. We have to counsel patients on how to quit smoking when starting tuberculosis treatment. If they do not quit, tell them to avoid exposing others to their tobacco smoke. Also include follow-up and support for smoking cessation in patient monitoring. The vast majority of TB cases can be cured when medicines are provided and taken properly. Tuberculosis symptoms can seem to go away, but the illness often reactivates. An estimated 20 to 50% of TB impairment after competing treatment. I also want to tell you about the guidelines for tobacco control that I did for Dr. Sachdeva at that time in the ministry when the guidelines for TB were being reviewed. So a few years back, when I was asked to review the tobacco guidelines for TB, I had also included that anyone the TB patient goes to, anywhere he goes to, any premises for a test or even for DOT administration, he should not pass through any passive smoking anywhere. People have to take utmost care that there is no passive smoking. Nobody is smoking on the way and nobody is smoking at the premises. Thank you. This is all I wanted to start with, and let's go to our scholars and see what they have to say. Thank you.
So, thank you, Dr. Miraji, and thanks for your introductory remarks. And we know that you have a lot of experience working with the tobacco patients, the TB patients, and offering them some behavioral therapy and even the cessation services. And I know that you have worked a lot with Dr. Sachdeva and Dr. Rana. So thanks for your introductory remarks. Now I'd like to call upon Dr. Sachdeva. So Dr. Sachdeva is our chief guest. He is President and Chief Medical Officer, Hon'ble Diagnostic, and he's a former DDG from Ministry of Health and Family Welfare. And he has got more than 35 years of experience in public health, and he has held senior positions in the Ministry of Health, Government of India, former head of India's National Tuberculosis Elimination Program and National AIDS Control Program. He has served as a nodal officer at the Global Fund. I may tell you that the National Tuberculosis Elimination Program, earlier it was called the National Tuberculosis Control Program, revised, RNTCP. He has served as a nodal officer at the Global Fund for TB, HIV, and Malaria, and held the position of Regional Director, Southeast Asia, at the International Union Against Tuberculosis and Lung Diseases. He is actively involved as an expert in various committees and technical working groups, and has over 95 publications in peer-reviewed journals. So, thank you, Dr. Sachdeva, for joining us, and over to you. Thank you. Sir, you're muted, sir.
Yeah.
Yeah.
Thanks, Dr. Gupta, and thanks for the opportunity to connect with people who are sort of promoting tobacco control. And I always find this group very enthusiastic and a very dedicated group who works on tobacco control. Even though the group is small, but their passion is very high. And I see that passion in Dr. Mira, Aghi, Dr. Rana, and all of you. At every they don't leave any place, any opportunity wherever they can sort of promote for tobacco control and its associated this thing. So a word about dignitaries, Dr. Mira Aghi, Dr. Rana, Dr. Ravinder. who is now the state TB officer of Himachal. So Dr. Rakesh Gupta, of course, Dr. Himanshu Gupte, Dr. Ashish Chawla, DTO from Amritsar, Mr. Arun Verma, Dr. Sanchita Gupta, Mr. Rajiv Chaudhary. So thanks for this opportunity. We all know India is the highest TB burden country. Most advertised, everybody talks about this, that we are almost 1/3 of the global TB burden. But even in tobacco, we are also a very, very high burden country. I mean, we are just at number 2. So both these epidemics are well entrenched in our country, and we need to address both of them on a war footing. Dr. Mira Aghi was letting us know that TB program was launched. I think Dr. Verma, Mr. Verma, was launched somewhere in 1960s, modified in 90s to revised National TB Control Program, and now it is National TB Elimination Program. The same, and it's quite mature at this stage.
Oh. You are requested to please keep yourself muted. I'm sorry. Only the speaker should keep unmuted. Thank you. Thank you.
So on the level of maturity, TB program is now quite mature. I mean, it's well entrenched within the health system, even at the community level. And most programs, including tobacco programs, should actually leverage on TB programs infrastructure and its reach to the most remotest part of the country. That is what COVID did initially. I mean, most of the TB program, district TB officers and TU, they were involved in COVID response at that point of time. If the same can happen with the tobacco control program, NTCP, National Tobacco Control Program, if they can leverage fully and completely on National TB elimination program, so I think that will be one fair degree of success. Dr. Mira referred to that we formulated guidelines somewhere in 2010 or 11. उसी time किया था ना मैडम, I think 2008-9-10 के करीब हमने first time we tried to integrate TB and tobacco together. Did a pilot project in 4-5 districts in the country, and as Dr. Rana will allude in his talk sometimes, that all the framework of integration of TB, tobacco is in place. There are integration strategies at national level, state levels, sub-state or district level. So everything is in place. What probably now needs to happen is a actual effective implementation. So somewhere down the line, I mean, everything in place. So in policy, there is an agreement. In practice, there has been agreement to implement, and in guidelines, there has been an agreement. So in policy, I think we need to demonstrate its complete integration somewhere. And I think Dr. Ravinder yahan baithe hain, he can do so very well within his state, Himachal. And Himachal has done a lot of work in TB. And then I think TB में हिमाचल को 2-3 साल लगा था पिछले, number 1 state towards moving towards elimination का award मिल रहा है, and Dr. Rana will use his goodwill with the state TB office of Himachal to push them to integrate it fully. So with this, if we are able to integrate and leverage on the National TB Elimination Program, I think there'll be a fair degree of success. Having said that, Dr. Mira said that TB is an infectious disease. I feel tobacco is an equally infectious. I mean, in other lighter one, behavioral way. I mean, it also spreads from one person to other, and we need to also break that chain of transmission through behavioral interventions, of which Dr. Mira Aghi keeps on suggesting. So, but I've also seen that passion with many of you. So, and quite hopeful that we'll be able to lead the way, eliminate or control both these epidemics together. And I wish all of you the very best to reach the objectives of both tobacco control as well as TB elimination. And Thanks for the opportunity. Thank you, Dr. Gupta. Over to you.
Yeah, thank you, Dr. Sachdeva. So, as you told us that guidelines were already formulated in 2010, and there's already administrative and political will to integrate anti-EP and anti-CP. And as already our Prime Minister has declared that it will be eliminated in 2025 instead of 2030. I think people like Dr. Ravinder in Himachal Pradesh and Dr. Ashish Chawla in his own jurisdiction, and Dr. Rana, as we all know, they are all working together, and Dr. Himanshu is also working in tobacco cessation and also with the TB patient. So I'm sure that with so many passionate people around, so we will succeed, sure. So thanks, Dr. Sachdeva. So over to Dr. Sanchika.
Thank you, sir. Sorry for that. Now, I would request Dr. Anand, sir, who is the Director of Southeast Asia Vital Strategies, for his talk on importance of TB tobacco integration towards elimination and control of TB and tobacco use in India. Over to you, sir.
So, good afternoon, all of you. First of all, thanks to Sipher and the Resource Center for Tobacco Control, PGIME at Chandigarh, for joining hands and organizing this very, very important webinar. Thanks, Mr. Verma and Dr. Sanchika. Our respected Dr. Mira ji, our guide and mentor. Dr. K.S. Sachdeva, I think, who was at the helm of affairs when all that discussions started way back in 2009-10, and formally they were formalized and final guidelines came up in 2018-19. So thank you, Dr. Sachdeva and Dr. Miraji, again for joining on my behalf also, because it is always something which is something very dear to me. My colleagues here in Dr. Himanshu Gupta from Mumbai, Dr. Ravinder, now he is a state program officer in the state of Himachal Pradesh, Dr. Ashish Chawla ji from as district TB officer from, I think, Ludhiana, and all the participants. So first of all, again, thanks for joining. You see, we have huge burden. Next, please. What is the country context? Right now, I would like to focus only India. Tuberculosis. So estimated, you can say 2.42 million incidences cases per annum. That is about 24 lakh TB cases every year. If we see what is the incidence, it comes out to be 193 new TB patients per 100,000 per 1 lakh population, as per global tuberculosis report. And what is current death? About 436,000, that is 4,36,000 deaths annually, which comes out to be 32 deaths per 1 lakh population. So huge burden, we always say. Dr. Sachdeva has already mentioned. So India, as far as tuberculosis, so it is India has highest burden globally. As far as tobacco use is concerned, we have second highest burden after China. It is second largest producer and largest consumer of tobacco in the world. Absolute number, almost 28.6% Indians use tobacco. And in absolute number, it comes out to be 267 million. That is 26.7 crore tobacco users in our country. And nearly it kills 1.36 million Indians every year, which is more than TB, HIV/AIDS, malaria, and road accident deaths combined. So 13.6 lakh deaths are because of tobacco use alone. 267 million tobacco users, and as per WHO definition, tobacco addiction is a disease. So you can imagine the number of patients we have. They are not simply tobacco users. For us, for public health professionals, that is a disease and they are patients. Next, please. So huge burden is there. So what is the problem? What is the problem statement? Problem statement is that tuberculosis and tobacco correlation, which is very, very important, but that is a neglected issue. High prevalence, and it is not something which has come to our knowledge very recently. High prevalence of tobacco use has been noted in studies looking at risk factors for TB since 1918. So it is more than 100 years when this kind of association was noted. In England and Wales, during this period of 1871 and 1880, mortality from pulmonary TB was similarly high. At that time, you see, in both males and females, the mortality was same between this period. But later on, it changed because of tobacco use, increased tobacco use among male patients. So between 1941 to 50, TB mortality rates of males was much higher than the female. How that happened? Earlier it was same because of smoking among them. TB patients were more likely to be heavy smokers than control patients. Similarly, another very, very old study, Brown and Campbell in 1961 and Luce and Chamberlain in 1963, they investigated both smoking and alcohol use and found that alcohol drinking and smoking was major factor associated with tuberculosis. So this is very old association. Next, please. There are many other studies globally which has been done, many systematic reviews, meta-analysis. So these are a few analyses which established some kind of association by Karen Salma and others. Dr. Mira ji closely worked with her also, then Linian and others, then Bates and others. So large number of studies, 42 papers, 38 papers, 24 papers, where a systematic review and meta-analysis were done and some kind of association was formed. Similarly, reviews on tobacco and TB by P.D.O. Davis, by C.Y. Chan, M. Madhukar Pai. So there are many other associations, many studies which have been reviewed in last many years and found this association of tuberculosis and tobacco use. Next, please. Latest systematic review and meta-analysis by Indian authors. That was by Jaydeep Patra and others, which was published in PLOS Medicine 2015. What it found? It found that secondhand smoke exposure is associated with an increase in the relative risk of latent TB infection and active TB. So even secondhand smoke exposure, which Dr. Mira ji was referring, TB burden is highest in countries with increasing secondhand smoke exposure. So previously I was working with TB control program, and when I came to tobacco control, I found that all TB burden, high burden, tuberculosis cases were also high burden cases where tobacco use is high. So definitely there is some correlation. Next, please. There are many other studies from India. People often ask what are the evidences from our country. So smoking cessation intervention for pulmonary tuberculosis treatment outcome. So this study found that there is high incidence, high prevalence of tobacco smoking among people with tuberculosis. This is important finding, which even another study which we did that was also important finding poor treatment outcome. All the tobacco user or the smokers, most of the findings are from smoking, not from other smokeless tobacco. But definitely there is an association. But studies mostly are for smoking form. So there is poor treatment outcome are more common among smokers. So this was another important evidence from this study. So it will also mention that still we don't have that enough evidence, so we need more randomized control trials to establish that kind of correlation. Next, please. Union. So Union has done a lot of work, International Union Against TB and Lung Disease. So they published a book way back in 2007, first with the WHO. There is a TB tobacco integration manual. Thereafter, we call it as a green book. So in 2008, and then again in 2010, that was revised. So Union has done a lot of that kind of work, and they also reviewed all such publications. Article such was performed independently by 2 persons at the Union using PubMed, Union database and Google Scholar. Articles in English, they were examined for inclusion, and articles not providing information on country of study, sample size, population sources, age, sex, and effects ratio, they were excluded. So this was a big review which was done by the Union. Next, please. So what were the findings? Next, please. Next, please go for next. I would just like to. So what was how the results were interpreted? First was strong evidence. When we say that there is a strong evidence, at least 2 high quality cohort and 2 high quality case controlled studies, if they provide consistent finding, we say that there is strong evidence between tobacco use and tuberculosis disease and its outcome. Then moderate evidence, when we say that there is moderate evidence when 1 high quality cohort and 2 or more high quality case control studies, they provide some kind of evidence, we say moderate evidence, or 3 or more high quality case control studies. Next, please. Then limited evidence is provided by generally consistent findings in a high quality single high quality cohort study, or 2 high quality case control studies, or 3 or more high quality cross sectional study. Then we say that evidence is limited and not enough evidence. So in that way, that analysis was interpreted. Next, please. Next, please. Next. Yes. So what were the results? How many papers were considered in
Please
this?
keep yourself muted. Only the speaker should, yeah.
So how many
All of us,
studies
please
were
keep.
how many studies were included in this Union systematic review and meta-analysis? So a total of 1,800 plus references were first identified. The full text of 192 articles were screened, and a final inclusion of 42 articles containing 50 studies for data extraction were used. Next, please. So, next, please. So, please go to the next one. So this slide is important. 7 studies found that tobacco's active smoking, all seven studies were found eligible, and all 7 studies established that active smoking has a significant association as far as infection is concerned. So tuberculosis, that is smoking, leads to infection also. Even passive smoking, passive means at that time we used to say secondhand smoke exposure. 1 study was seen eligible, and 1 study found significant association. That similarly for tuberculosis disease, in conversion of infection to disease, it was found that smoking, 19 studies out of 19 studies, 18 studies found that smoking leads to increased tuberculosis disease. That is conversion of infection to disease. And 4 studies out of 5, they found that it also passive secondhand smoke exposure is also leads to tuberculosis disease. Similarly, retreatment TB means when person gets TB again. So out of 3 studies, 2 studies established that patient can get TB if he or she continues to smoke or starts smoking again. Patient delay means getting treatment. So that was again a significant association was found. Treatment default, all those smokers who continue to smoke, they are likely to default for treatment. Similarly, smear conversion from positive to negative. Out of 3 studies, 1 found that there is delayed smear conversion. Severity of disease, all 2 studies found that TB disease is more severe in patients using tobacco, so smoking. Similarly, drug resistance TB, death after treatment, TB mortality. Please see the last one. All 5 studies found that TB mortality, that is TB death, is high among patients using tobacco or smoking. So this is clear. TB, tobacco, smoking is related to every stage of disease. Every stage, from infection to disease to treatment outcome, everywhere, until death. Till death. 40% deaths in TB patients, male TB patients, that has been associated with smoking among them. So there is clear association. It is fully established. Next, please. Active cigarette smoking as a risk factor for tuberculosis in young adults? Yes. So even in very young adults. So please see the last line. There was a dose-response relationship between the number of cigarettes smoked and the risk of tuberculosis. So amount of smoking is also important for as a risk factor for tuberculosis. Next, please. Please, next. Yes, very quickly. Another study which found on exposure to tobacco smoke and clinical manifestation of tuberculosis. Now, this is again very important. Myself being a chest physician, I found this every time. That smokers were more likely to have cough, dyspnea, chest radiograph, chest X-ray appearances of upper zone involvement. So smokers are also likely to have similar symptoms, and even if patient and there is delay of regression of all those symptoms, they are having cavity, miliary appearance of tuberculosis, positive sputum culture. So symptoms are also more are likely to be severe and more likely to continue in those patients who are using tobacco. Cigarette smoking is associated with cavity or a positive smear in these patients also. How that affects basically? Cigarette smoke, already I think Vermaji mentioned that about immune system. So definitely, the smoking leads to decreased immune system of the person. Although the number of alveolar macrophages, these are defensive mechanisms within the lungs, but smokers' alveolar macrophages, which kill bacteria and phagocytose, they become weaker. So such patients are likely to have more disease from other bacteria also, like Staphylococcus aureus and Listeria monocytogenes. Similarly, their T cells, they have decreased ability to proliferate in a response to T cell mitogens. So this is again, so there is weakening of immune system in all patients who are using tobacco or smoking. Next, please. Next, please. So association is clearly established at every stage, from infection to disease to treatment outcome to MDR-TB and to death. Every stage. So I often ask, is it possible to eliminate tuberculosis without tobacco control? So perhaps it is really very difficult. All those countries where smoking prevalence is high, they are also having high burden of TB also. So that association is there. So what is now, next please, what is the final now conclusion related to that? There is enough evidence to conclude that smoking is causally associated with tuberculosis disease. That argument has already been settled. Smoking has been found to be associated with relapse. Patients with tuberculosis need and should receive counseling and assistance in stopping smoking. Although tobacco use is a serious public health concern, tobacco control has so far been neglected in terms of tuberculosis control. You see, despite Dr. Sachdeva just mentioned, it was way back started in 2010. I was part of all those discussions. We also have some pilots, but even then it took so long in developing those guidelines. So in that way, it is still we find my observation that globally it is still neglected, including in our country, and maybe Dr. Vinder and Dr. Chawla, Ashish will be able to tell us. So I would request Dr. Vinder that please give us some snapshot what is happening at national level as well as at state level also. So potential contribution of tobacco control to fight against tuberculosis needs to be investigated. Next, please. So what are the opportunities? At what level? No, you see, we always talk about integration. Integration career. We should see synergy between different programs. So basically, at what level? Is it at patient level? No. This synergy should need to happen at highest level. Highest level was, for example, in our country, where is highest level? It is Nirman Bhavan. It is where both program teams sit together. So integration should start happening from policy development and planning. We need to develop, first of all, both program must recognize that yes, we need to see it is not only for TB control. It is equally important for tobacco control. Tobacco control program will get a great mileage, will get a great support. People will start quitting tobacco. Even the families, patients' families, will also recognize this. And if someone is smoking, even if patient is not smoking, if someone is smoking in a family, so that is something which will ultimately impact the TB patient also. So it will also educate them. So integration should happen at policy development and planning. We need to develop technical and operational policies for TB tobacco integration. ये सिंपल बात पेशेंट के लेवल पर नहीं है, रिमोटेस्ट लेवल पर नहीं है. जब तक यहाँ से कोई नहीं पूछेगा, until unless there is someone to ask from Ministry of Health, from both divisions, it is not possible. Lay down, we need guidelines for joint planning and monitoring. We need to build institutional capacity, collective joint trainings of program managers from both sides to ensure sustainability of joint activities of NTP, NTEP, you can say, and National Tobacco Control Program. We need to have a joint activity, training on joint activities, joint supervision also very important, and monitoring of TB tobacco activities. So, for example, now when TB control program is going to have its review, so they or monitoring missions. So whether they include this component, whether the teams look at monitoring of TB tobacco activities at grassroots level, at district level or not. So we delivering TB services in smoke-free environment. This is very important. We need to see that all healthcare facilities are TB-free, are tobacco-free. Even a smoke-free environment, not only, but also for home. So home should also be tobacco-free. Tobacco cessation among TB patients. So that is something no TB patient should be left behind. He or she must be asked about tobacco use habit. And if patient is using tobacco, we need to provide tobacco cessation. Partnerships are very important. Next, please. Very. So I think this is already clear. Significant number of TB patients use tobacco with important implication for TB control. Introducing tobacco cessation into TB program is feasible. You see, in early phase, I used to explain this way back in 2009-10 because everyone was saying that there is huge burden on TB patient, TB program already, how they are going to do tobacco cessation, how they are going to ask about tobacco use history. But all the studies that have already mentioned that introducing tobacco cessation into TB program is feasible and can be coordinated in a simple and cost-effective intervention that is carefully monitored. लेकिन जरूरी है लास्ट confidence and rapport building with patient is very important to extract the history of tobacco use. Often a patient do not give history of tobacco use if we ask very casually. यदि हम रैपिड अच्छे से कॉन्फिडेंस बिल्डिंग रैपिड बिल्डिंग के साथ if we ask a patient of tobacco use क्या आप तो then only then counsel and get follow up information for undertaking a good suggestion intervention. So this is very important point. Next please. Next, there are many publications. Now I think Dr. Himanshu Gupta will also share other thing, Dr. Vinder, Dr. Chawla. So this is one publication done under leadership of Dr. Kuldeep Sachdeva, promoting tobacco cessation by integrating brief advice in tuberculosis control program. Dr. Mira ji was also part of this all those training program. Similarly, there is another study from Dr. Sonu Goel and others, effect of a brief smoking intervention on adult tobacco smokers with pulmonary tuberculosis. So it was a cluster randomized control trial from North India. So I won't go into too much detail for that. Next, please. Next. So these are some technical resources. On left side is a WHO Union monogram of TB and tobacco control. Then it was another guide by Union on smoking cessation and smoke-free environment for tuberculosis patient. Next, please. Next, please. Next, please. So these are a few initial discussions. We can see Dr. Sachdeva there. So you see in 2015, this study, some initial workshops started happening. So there is a representative from WHO and from Ministry of Health and Family Welfare. Next, please. Next, please. Next. So this was finally in 2018. You can see Dr. Swastijar. He is also sitting along with Dr. Sachdeva. So this was a workshop where our joint TB tobacco collaborative activities and guideline was finalized, and then it was released by Union Health Minister. I think it was released by at that time perhaps Nadda Saab. So this was a guideline released on World No Tobacco Day in 2018. So we have now this framework, and TB tobacco collaborative activities framework, which will guide us. So maybe Dr. Vinder will tell us about the performance, Dr. Chawla. So thank you very much. And next, please. Next, please. So thanks. So this is just to give you a snapshot that what is the evidence about this association of tuberculosis disease and tobacco use and smoking. So thank you very much, and over to Dr. Sanchika and Dr. Rakesh Gupta ji.
Thank you, sir, for an excellent presentation. I want to summarize the presentation. Both the active and passive tobacco smoke exposure has a direct correlation on getting a tobacco fresh infection, a disease, retreatment of tuberculosis, patient delay, default, smear conversion, severity of tuberculosis, drug resistant, and even mortality. So if we look forward for first of all, the partnerships and collaboration is very, very important. And also introducing tobacco cessation into TB program is one of the most feasible and also cost-effective intervention. And also reaching out to each TB patient is the way forward to complete our targets as set by the Ministry of Health and Family Welfare. Thank you. So now I also request Dr. Rakesh sir to add on.
Thank you, Dr. Sanchika. Actually, it was a very motivating and I think it is an excellent presentation from a person who has actually worked in the field. And since he is a chest physician himself, so he knows exactly why this anti-EP and anti-CP collaboration is important and why the tobacco cessation for each and every patient of tuberculosis using tobacco is important. So thanks a lot, Dr. Rana. Thank you.
Over to Arun, sir.
Thank you, Dr. Sanchika. Can I have this PPT? Who is the next speaker? I think Dr. Ravinder is the next speaker.
Yeah, Dr. Ravinder will be speaking now.
Yeah, thank you, Dr. Sanchika. So our next speaker of the day is Dr. Ravinder Kumar ji, who is a State Program Officer, National Tuberculosis Elimination Program, Himachal Pradesh. Everybody knows that Himachal Pradesh is well known for implementing all the policies related to tobacco as well as TB. Dr. Ravinder Kumar will be speaking, addressing the gathering on the TB tobacco comorbidity and experience from Himachal Pradesh. Dr. Ravinder Kumar, he is MBBS from the IGMC Shimla. He's a Masters of Public Health from PGM at Chandigarh, currently posted as a State Program Officer, National TB Elimination Program in the state of Himachal Pradesh. Prior to this position, he worked as WHO consultant on TB program in Himachal Pradesh. He has also worked as a technical officer, tobacco control in the union from 2012 to 2014. Dr. Ravinder has been fellow of the John Oxford Leadership Program in Tobacco Control. He has nearly 20 publications. So over to Dr. Ravinder.
So, Dr. Sanchika, you'll be presenting the presentation?
Yeah.
Okay, thank you.
Even I myself can present because it has some animation, so it will be easy for me.
Okay, you
Is
can
that
do
okay?
it. Yeah.
Right, sir. Just
ठीक
give
है
me a
सर,
minute, please.
आप जैसा ठीक समझे.
जी. So my presentation is visible, sir?
Yeah, it is.
Yeah, thank you so much.
Thank you.
Sir, request, sir, sorry sir to interrupt. आप slide show mode पे कर दीजिए. Yes.
Okay. Good afternoon, everyone. So I find myself very privileged to be back in tobacco control world. So all my mentors in my public health career are today, and about 10 years back, I was working with the International Union as a tobacco control under the leadership of Dr. Rana sir. And Mira Aghi has been always giving blessing to me. And whatever I could do in my public health life, I owe this thing to Dr. Rana Singh ji and Mira Aghi ji. Thanks to Sipher team to connect me back to my real passion, basically. So after having a few years as WHO consultant, now I'm back in state as a state program officer TB, and a little bit we have done for TB tobacco in the state. I will discuss that with all the August gathering. So as you know, Himachal Pradesh, it is a hilly state in northern part of the country, and it is having 12 districts. Our population is about 75 lakhs. As far as TB is concerned, we recorded TB notification rate of 216 per lakh per annum in the year 2023. So our notification rate is one of the highest in the country. It's not only that we are having very high disease burden, but at the same time, the case finding efforts of Madhya Pradesh are excellent. I can say where the country average case finding presumptive TB examination rate is about 1200 or 1300 per lakh per annum. The case finding efforts of Madhya Pradesh are over 4000 per lakh per annum for past 3 or 4 years. So we are testing more. As a result, we are also getting more. Now, as far as the burden of tobacco is concerned in the state of Himachal Pradesh, in first GAT survey.
Dr. Ravinder, can you be a little away from the mic? Your voice is cracking.
Okay, now fine, sir. Okay.
Yeah.
So as per the GAT survey, in first round, that is 2009 and 10, so current tobacco use in any form in Himachal Pradesh was 21%. We got very good national tobacco control program implemented in the state of Himachal Pradesh. Multiple strategies were adopted, and again we did these things under the guidance of Dr. Rana sir, and we got a decline in tobacco use, which is shown by the GAT survey round 2, 5%, 6% decline we got. But still, there is a burden of tobacco use in the state, which we can see from the GAT survey report. Now, this is the document which the work on which started in 2010 or 11, which Sachdeva sir said, and then Dr. Rana and union team, and then finally in 2017, the first draft of this document came, and then in 2018, this national framework for joint TB tobacco collaborative activities. It was released by Government of India. So this is the, I would say this is the first document, formal document, which was made by a ministry involving all the stakeholders along with World Health Organization. So what was the purpose of this document? Basically, the purpose of this document was to, the TB tobacco collaboration was the aim to reduce the burden of comorbidity due to TB and tobacco use through collaborative activities between these two national programs. So earlier it was RNTSP, 2020 onwards it is National TB Elimination Program. And two major objectives of this collaboration was to identify tobacco users among registered TB patients and provide them brief advice for tobacco cessation and motivate them to quit tobacco use. And another major objective was to screen for active TB symptoms in tobacco users registered at tobacco cessation centers, and for that matter, drug de-addiction center in state of Madhya Pradesh and National Tobacco Quit Line. So these were two major objectives of this collaborative activities joint framework. Dr. Rana said, very nicely said, I think his entire presentation was basically on the data and facts. But the summary of that is there. The exposure to tobacco smoke, it increases risk of TB infection and risk of developing TB by 2.5 times. It affects clinical manifestation and increase risk of recurrence among TB patients by 3 times. It increases TB mortality and resistance to anti-TB drugs by 4 times. So whether it is first-hand smoking, direct smoking, whether it is second smoking or a passive smoking, it kills basically. And Dr. Rana very rightly said, 38% of the TB deaths, the attributable cause is basically exposure to tobacco smoke, whether it is primary or a secondary. So it is a menace, it is basically a menace. And additionally, how it affects basically, cigarette smoke causes ciliary dysfunction, it reduces the immune response and defects in the immune response of the macrophages with or without a decrease in CD4 count. Thus, the susceptibility to infection with mycobacteria, it is increased. It increased the risk of latent TB infection, culture conversion is delayed, and the disease mostly becomes cavity disease, which is basically, this is an advanced stage of a disease. There's a treatment delay, there's a treatment loss to follow up. Everything happens because of this. And it's not only the primary smoking, but the passive smoking or exposure to second smoke is also a risk factor. And many studies have said that the smoking suggestions are an effective way to decrease treatment failure and drug resistance. So we have a 2021 the National TB Elimination Program data. For the state of Madhya Pradesh, I have the latest data, but national data I could access actually 2021. After this joint collaborative framework, many states and districts, they started doing their work. And in 2021, whatever number of TB patients we could notify, about 20 lakh, 25 lakh, we were actually knowing the tobacco use status of about 74% patients. And out of that, we found that 12% of the TB patients, they were identified as the tobacco user. And they were screened and then they were offered some cessation services, and 30% of them were linked to the tobacco cessation services. And I'm in my next slides, I'm sharing the highest level formal institutional structures which are there in the states and the district. Basically, these are TB comorbidity committees. So these are there in place. So there may be certain variation in different states, but at least for state of Himachal Pradesh, these bodies are there. The meetings are taking place very regularly. So let me come to. So these are the two programs. At national level, we have Central TB Division. Right now, that Central TB Division is not in Nirman Bhavan. I think portion of that is in Nirman Bhavan, but there is a Jeevan Vihar building, so nearby to Nirman Bhavan probably. Central TB Division is shifted there, and there is a national tobacco control program. So national level, these are the two big structures. At state level, there is a state TB cell and state tobacco control cell. Both they are under the umbrella of National Health Mission. So earlier, the TB control program used to be a vertical program, but it's not now. So after National Health Mission, it's there in the National Health Mission. It's a big umbrella, and all these programs are there only. Then there are district TB center, and in National Tobacco Control Program, there is a district tobacco control cell. And in the National TB Elimination Program, we have TB unit, we have designated microscopy center, we have DOT center. And for National Tobacco Control Program, there are tobacco cessation centers. We are having 14, and then there are many drug de-addiction centers, so which are decentralized up to the civil hospital and district hospital, even community health center. So there is an interface of these programs where the collaboration is possible, basically. Right now, this is something I think programs suggested. I mean, these collaborative activities, they suggested that we should go like this only. When I'm presenting the experience from Himachal Pradesh, so many of the activities we actually are doing like this only, but definitely there is some gap, and with the due course of time, it will be improved. But otherwise, I think this is the main slide where how these two programs they can basically collaborate. So on right hand side, there is a TB unit, DMC or PHI. Here what happens? So person having TB symptom complex means presumptive TB cases come to these centers. Here they are tested after when they are diagnosed as a TB patients, and they are initiated on a DOT treatment. So this is normal thing for the TB person to do like that only in our program. Now, whosoever is initiated on TB treatment, they are basically asked, counseled whether they use tobacco in some or other form, and whatever they say, we capture that on a TB treatment card. We have a TB notification register, and then we enter into the Nikshay portal. Now, if some person is using tobacco, he is a current tobacco user, then that person is given brief advice, again that 5A and 5R thing, by the concerned medical officer who initiate the treatment. And in Himachal Pradesh, we have a pharmacy officer who basically initiate the treatment. So pharmacy officer and doctor, the first person who give brief advice to the person who use tobacco are the doctor and pharmacy officer. After that, when they go to the field, then brief advice it is given on bi-weekly basis by whom? By the health worker, the CHO, and their treatment supporter. Now, on bi-weekly basis, we assess whether they are still using tobacco or they have quit it. If they have quit, then this is the good thing. So we assess their quitting status on monthly basis, because every month the TB patient who is on treatment, he has to visit the nearest PHI to get his, basically in Himachal we have started another things also, where one person has to come to the hospital to get his weight checked, and other the DTBC services and other thing also. So whatever status is there, it is updated, but this person doesn't quit. Then in first 2 months, we again ask for the brief advice again and again. And we say that, brief advice is very effective when it is implemented in a cascade. There are 5 people in a healthcare chain network, and everybody give the brief advice. That is more effective as compared to one brief advice for hours together. So we repeat this, and we wait till the end of the intensive phase. So in first 2 months, if the brief advice, it doesn't give us the result, then this is the high time to refer this case to the nearest TCC or nearest drug de-addiction center or the National Tobacco Quit Helpline, which is instituted by the ministry. And then we again assess his quitting status regularly. And if he quit, we update the status in the treatment card, and then we update in the Nikshay portal. And in tobacco cessation center, this is other arm. This is other arm basically. So the left side is the other arm. So there are tobacco cessation center 14 in Himachal. There are 103 drug de-addiction center where this tobacco cessation advice is given. They are also having their other beneficiaries. So we also request them, see, if these people are having chest symptoms, then take their sample and directly test them in a CBNet. And if they get TB diagnosed, then we refer these back again to the TB unit and diagnostic microscopy center. So this is basically the protocol which ministry, both the program, National TB Elimination Program, National Tobacco Control Program, their experts, they came out with this protocol. And if you call what is the status in Himachal Pradesh, I could say it's not 100%, but it's in a good 70 and 80% in place in the state, which I can explain you in the next slides. Now, so these are 2 bodies. I'm not sure in how many states this is there formally instituted, but in our state, yes, it is. So you can see the notification on the left hand side. This is the state technical coordination committee on TB comorbidity. So you can see all the departments and divisions which are associated with the good outcome, treatment outcome of TB patients. They are the member here, and the chairman is Secretary Health. We very regularly conduct this meeting. All the members are there. Whatever the issue related to is related to comorbidity are there. We have there, and we have Dr. Gopal Chauhan, our champion program officer for last decade, I must say. We both are groomed by Dr. Rana and Mira Aghi ji. So we very regularly we conduct this meeting, and whatever issue related to tobacco, and you can see the NCD and the National AIDS Control Program very frequently. And on the same pattern, all district, they are having district level TB comorbidity coordination committee, and chaired by deputy commissioner, and all the members are there. So we are conducting very rigorously every 6 months in the state, and many districts are doing more than 2 times in a year also, and the meetings and everything is funded by the National Health Mission, right? Next thing, so when we see the TB treatment card in the lower right half, so there is one column where we capture the tobacco user status. So current tobacco user, yes or no? If yes, whether smoking, smokeless, or both, and whether we have linked for cessation, yes or no. And then we assess the status of tobacco use exactly at the end of treatment, that is mostly after 6 months, and then we mark on the treatment card. So after marking on treatment card, now we open the Nikshay portal. So any of the speaker, if you are not familiar with the Nikshay, so this is our web-based tool made by a ministry where we capture real-time detail of a TB patients. So one of the detail is comorbidity. So login ID and password, they are there for every official, starting from health and wellness center to up to state TB officer. So in whatever capacity, I mean, I'm working as a state program officer TB, so I have the access of entire state. So where we click on comorbidity, and after that there comes this interface. So whether current tobacco user, unknown, positive or negative, tobacco type, smoking, smokeless or unknown, linked for cessation, yes, no, unknown, status of tobacco use at the end of quit, not quit, unknown. So this is our entire data related to the tobacco status of a TB person is captured first by manually in the treatment card, and also in the TB identity card, and then it goes to the Nikshay portal. Next. Now, how our state is having a good performance in key performance indicators. The only thing is that probably this is the only state where National TB Elimination Program, it is reviewed on full 1 day by Chief Medical Officer, involving all the block medical officer, entire TB staff every month for last 4 years. And at the same time, we have decentralized this review to the block level also. And related to this tobacco cessation, this is the slide we are reviewing for last 4 years, where BMO asks every medical officer in charge how many patients are notified in this month in your district, in your PHI, patients with known tobacco usage status, for how many patients you know whether they use tobacco or not. So this is asked, what is the gap in the performance? TB patients using tobacco in any form, how many has been linked, and what is the gap in these suggestion services? So this is something very rigorously our block medical officer and our chief medical officers, for that matter, our state TB officers, so we are doing this thing for last 4 years. And you can see this is something, it was not actually asked by Central TB Division for us to do, but our team has been very, very innovative. So this is the treatment card. Many people wrote by manual handwriting, तंबाकू छोड़ने के लिए सहायता, तो ये नंबर है. So whosoever is tobacco user, that number is there, and for the first time our treatment supporter, they just enter this number in their mobile and make first call. That number is also written on the treatment card. So there is another very innovative district TB officer from Amirpur. So he made this stamp also. So there is a stamp where tobacco quit helpline number. So it is put on a stamp also. So person is basically advised, then a stamp is also put. So that number is now everywhere. So whoever is a tobacco user, that number goes there. First time call is made by the treatment supporter, and then number is put there. And many district TB officer, they have printed this number on the on the paper itself. So everybody is doing their own bit. No, so we just float the idea that this number should be number should go on to everybody, and these are the posters and banners which are printed by National Health Mission, and then they are placed in many treatment centers across the state. So you can see this is from Jilla Swasthya Vibhag Shimla. So many people, so these are the material which we got from Central TB division and then shared with the CMOs, and many of them printed, and they are placed very well in the in the treatment centers only. And these are our facilities. We are having 14 tobacco cessation centers where pharmacotherapy is also available with NRT and non-NRT. We are having 103 drug detection centers. So they are totally decentralized. The specialty of this drug detection center is that we are having a qualified counselor posted in most of the centers, about 50, and in other places we have a trained medical officers. We were trained by NIMHANS on drug detection centers, and they are very well trained in tobacco cessations. And entire staff, the DRTB coordinator, STS, TBHB, they all are trained in the tobacco cessation. We have one center, STDC Dharmpur, where 2-3 days training was there on TB, and we have half day good session on the tobacco use and counseling. And we are lucky in 2015 or 16 when I joined WHO, so I got help from the union, Dr. Rana Jay Singh sir, and we had 1, 2 or 3 days a big session on tobacco cessation, TB tobacco collaboration right here in Shimla. So we have trained block medical officers and DTO also in this aspect. Our ASHA workers are also well oriented about this concept of brief advice, and they are the one, because they are the treatment supporter, and they are the one who basically in first 2 months of IP phase constantly they are actually asking the tobacco user to quit tobacco all the time. They are after this, and if nothing happens in the first 2 months, then tobacco cessation and quit line and other things, they come into the play. And we are also having 104 telephone helpline. It is for all the national health program of the state, and where any person can take the tobacco cessation help also. So this is the little bit infrastructure of tobacco cessation in Himachal Pradesh. And this is my last slide. This is 2023 data of Himachal Pradesh. Entire data is from Nikshay portal. It is live, and it is one of the key performance indicator. You can see we recorded 15,647 notification in the year 2023, and we literally could get the information on tobacco use status of almost everybody. Our percentage is 97%. Many of we couldn't, because many patients were not put on treatment, got defaulted, died or something like that. But this is one of the good number. And you can see out of these numbers, 11.7% were tobacco user at the time when we started their treatment. So this number is just like whatever GATS survey tell us, almost same. And in our state, mostly people are using smoking form of tobacco. Smokeless is very less, and providing them complete brief advice and tobacco cessation. 90% of people, they were linked basically. They were linked with the nearest TCC. They were linked with National Tobacco Control Helpline. They were linked with the drug detection center, and when they completed their treatment, we could get the fairly good success of 47%. They actually quit when the treatment was, when the treatment was completed, they actually quit. But we are not happy with this. We want to increase this 47% to as high as 80% and 90%. And then we want to follow these people by every 6 months, because state has started post-treatment follow-up service for all TB cases. So tobacco use is one of them. So this is one of the indicators. So once I complete my treatment today, after 6 months, again I will follow for this. Then again 6 months. And for next 2 years, if some people stay abstinence for tobacco use for say next 2 years, I would say that person will not get recurrent TB, and we will aim for that. So as I said, we just started. We are not satisfied whatever we have done, but it is just the beginning. And I got my affection for tobacco control back. So with full rigorous and support from Dr. Rana and the other team, tobacco control team, we will definitely implement this model 100% with 100% conviction in this state. Thank you so much, everyone. Thank you for patiently listening.
So thank you, Dr. Ravinder, for an excellent presentation. And I know how passionate you are, since we have been working together in the field of tobacco control since almost 2010. And I think all STOs and DTOs, they need to see these presentations. So I actually clicked some of the slides why there's need for collaborative activity between TB and tobacco. And you said that the risk of tuberculosis is increased by 2.5%, risk of recurrence three times, and then the risk of death is 4 times. And you also told about the NTP and NACP collaborative framework. Then you also shared with us the state tuberculosis comorbidity committee and district TB comorbidity committee. I think that is not in all the states, I'm sure. Then you also showed us the TB treatment cards you use. And it's really excellent work and can be replicated in all the states and the districts. So thanks a lot, Dr. Ravinder. So over to Mr. Verma, please. Thank you.
Thank you, Dr. Thank you, Dr. KG. Just to add a little line to your, summarizing this for Dr. Ravinder, that after having done so massive work meticulously by the Himachal Pradesh, he's so, humble to say that they are not satisfied what they have done. Thank you so much, Dr. Ravinder. Now over to Dr. Sanchika for the next presentation.
Thank you, sir. Now I would request Dr. Himanshu Gupta, sir, from Narottam Sexaria Foundation. Sir is currently on the position of Vice President in Health. Sir is a medical doctor with master's degree and PSM and has an extensive work in the public health for more than 20 years. Sir will be talking on the topic of integration of tobacco cessation and TB management by NGOs in urban India. Over to you, sir.
Yeah. So, good afternoon, everybody. Good afternoon to the dignitaries, Dr. Sachdeva, Dr. Mira, Dr. Ravinder, and thank you for that excellent presentation. Of course, thank you to Dr. Rakesh Gupta, Dr. Rana for having me on this, and good afternoon to all the participants. Like the comment from Dr. Rana, there are 100+ participants currently, and thank you for patiently listening to this. I will be sharing my presentation. I hope this is visible.
Yes, sir.
Yeah, it is visible.
Yeah, sure. Thank you. So the topic as introduced is integration of tobacco cessation and tuberculosis management by NGOs. So here I would be looking at the perspective from the NGOs. So we've heard an excellent presentation of what the program is doing and one of the ideal states or the best performing states presenting how they have integrated the two programs and are successfully implementing it. So this is an operational research study that we had conducted in Mumbai. So this was at the time of the RNTCP, when there were dot providers and NGOs were actually involved in dot provision, as in they had their own TB treatment centers and patients were coming to the NGO TB treatment centers and for dots and were being supervised for dots. So just a brief introduction before we go on to the presentation. So I myself belong from the Narottam Sexaria Foundation. It is an NGO based in Mumbai, and we have started a program called Life First. So Life First is a tobacco cessation program. It is being implemented in collaboration with the Salam Bombay Foundation in some of our settings. So basically, it is the main component of the program is a counseling-based cessation service, which is provided in healthcare settings like primary healthcare centers, tertiary hospitals, both to OPD patients as well as inpatients. We also work with the school program or the school setting. We have a workplace component of this program. And in addition, we have these operational research initiatives wherein we are trying to create models of tobacco cessation. So like we've seen in the previous presentations, a lot of evidence or a lot of data, a lot of studies are based on smoking. So like there is a lot of association being established between smoking and TB. Similarly, there is a lot of evidence on smoking cessation or practices, but whereas smokeless cessation is coming up recently, and there is not much evidence. So this is where we come in, because a lot of tobacco use in India is mostly smokeless tobacco use, and so the cessation has to be catered. So the various models from the West have to be adapted, and this is what we have been doing. And one such operational study that we had conducted was in the TB setting, which I am presenting briefly. So I will not go into the details of the background. All my previous presenters have already spoken about this, with the linkages of TB and tobacco. This is this big dual epidemic that we are facing. We have seen the numbers of how large this problem is. What is the effect of tobacco on TB, right from infection to its treatment outcomes? We also have seen that smokeless tobacco is also associated. It's not just the smoking part of it, but also the smokeless tobacco that is associated with tobacco, TB. And one of the positive things over here is that within 6 weeks of cessation, most tobacco-related immunological abnormalities are reversed, which means that there is higher chance of treatment, positive treatment outcomes or successful treatment outcomes if there is tobacco cessation achieved among the TB patients. And that has been the mainstay of the TB tobacco collaboration, wherein tobacco cessation to TB patients has been promoted for a long time. In terms of where we are currently, or the efforts which have been made on cessation integration, these have been done since a long time. We have heard about from 2010, there were efforts of collaboration, the guidelines have come out. There have been some gaps in implementation, though it has not been uniform. It has not been the same across all states or districts within the states also. And we have seen that while there is these excellent states which are performing very well, there are certain parts where this is not implemented. And this is where the role of NGOs is coming in. Overall, NGOs have been very well integrated into both the national TB program as well as the national tobacco control program. And we have been functioning at both the levels. So this is where the cessation integration within the tobacco, within the TB treatment protocol is falling in. And I am now presenting what we have done and why we have done the way we did it. So basically the objective was to see whether this is working or not. So this was something which we tried before the TB tobacco collaborative guidelines came into being. So which we just saw that in 2018 they were released, and then further they were implemented. So this was just for that, where the guidelines were not available. The pilot studies of these were being conducted in 4 states, like Dr. Rana mentioned. And at that time, we were facing these issues that on one hand, we were implementing tobacco cessation program in different settings, and we were aware about the TB setting, the TB patients and their issues related to tobacco, but not much was happening at that level. So at that point of time, we initiated this operational research, in which the basic was to understand the issues around feasibility, effectiveness, and also looking at the provider perceptions of integrating these tobacco cessation activities within the TB control program. And for that, we had, of course, this intervention study or this action-based study, which we conducted. And there was a qualitative component to it, wherein we also looked at the provider perspectives by actually interacting through detailed in-depth interviews with these practitioners or with these TB treatment providers who were involved in providing this cessation advice. And so quickly, what we have done is we worked through 27 NGO-run dot centers, as they were called at that time, in the city of Mumbai. So these centers were receiving patients from the program, the RNTCP as it was called at that time. So they were diagnosed as a part of the program, referred to the NGO dot centers, for further continuation of treatment. And at these NGO dot centers, the TB treatment was provided as per the guidelines, and these TB dot providers were trained by the RNTCP as well. So what we added on to this was that all TB patients who were enrolled in these NGO dot centers were to be screened for tobacco use during their initial part of the treatment. And for this, detailed training was conducted to all the dot providers. It was a one-day training which involved, of course, presentations, discussions, role plays for them to understand the subject. And the topics that were covered in the training were about tobacco, basically the basics of tobacco, the prevalence, what are the different products that we come across, the patterns of tobacco use, in details, the health effects, not just about related to TB, but the other overall health effects of tobacco, the benefits of quitting that could be attained if the TB patient is quitting tobacco. Also information about the National Tobacco Control Policy, and a little bit of theory about the basics of addiction, of why, how, types of addiction, all of that. And as a part of the intervention for the training, what was included is, like Dr. Ravinder mentioned, the 5 A's and 5 R's. These are the basics of tobacco cessation, which are part of the WHO protocol. And we also use the ABC approach. So this ABC approach is provided by the union. So Dr. Rana mentioned the Green Book, as it is called. So this is part of the Green Book, the ABC approach, which I will quickly talk about over here as well. So the intervention included that their tobacco users have to be, TB patients have to be screened for tobacco use as soon as possible when they are initiated into treatment. The definition, or the operational definition for a current tobacco user that we followed, was that anybody who has used any form of tobacco in the past 30 days. And of course, they were identified by verbal screening only. So it was about asking for tobacco use. Then that was the A of it. So ask about tobacco use. The B of the ABC is brief advice. So providing brief advice. So these dot providers were trained to provide that brief advice, which is a message to stop using, why they should stop using, what are the benefits of quitting, how and some tips of how to stop using. So that was also part of their training, and that was covered through this. So this was basically like coping mechanisms or withdrawal, how dealing with withdrawal symptoms, and that kinds of some tips and tricks. So there were the 5Ds, or the other some such methods which are adopted commonly in tobacco cessation. So those were provided to the dot providers, and they were providing brief advice to the identified tobacco users among the TB patients. And this was then followed up by counseling follow-up. So this is the C of the ABC. So cessation support, which was given through counseling and follow-up. So as a part of the TB treatment protocol, the patients were coming regularly to the dot centers. They were going to the DMCs for their sputum follow-up. So that the structure of the program was easy to add on this component. So each of the patient was followed up for their tobacco use, was given brief advice regularly at each of their follow-up up to the end of their treatment. And one additional component of documentation was added to this intervention, because ultimately whatever was being done had to be documented somewhere. So there was a small additional component of adding of what kind of tobacco, when was the follow-up done, what was the status of tobacco use during the follow-up, is what was added on to the existing documentation for TB treatment at that point of time. So this is in brief the flow of what we have been doing, and which I quickly mentioned. So right from the patient getting registered into the RNTCP, to asking of tobacco use, providing brief advice to the tobacco users, providing that cessation support, adding on the documentation, and finally the outcome of the tobacco intervention, tobacco cessation, was declared in terms of PPA. So this is point prevalence abstinence, which is a commonly used term for declaring outcomes of tobacco cessation. So generally a 7-day point prevalence abstinence is utilized. So this is basically the proportion of tobacco users who are not reporting as not using tobacco from among all those who had started the cessation program. So this is the percentage, or in general terms, it is also called the quit rate. So this is how we have explained our outcomes. So looking at what kind of and how many tobacco users that we had during that period is totally in that period, 2,132 TB patients were registered in those centers, and out of them 18%, that is 377 tobacco users were identified. Again, this was self-declared people who themselves said that they are using tobacco. Upon asking, were reported as the tobacco users. So the prevalence was higher among males like anywhere else in the country. So it was about 30%, and among females it was 5%. In terms of age group, again, it was the common TB age group, which was 35 to 55, wherein the tobacco use was also higher. If we see the tobacco use among pulmonary versus extrapulmonary, we saw that the prevalence was more in the pulmonary TB as compared to the extrapulmonary TB. And when we look at the TB category, as in whether it was a new patient or a retreatment patient, the prevalence was higher among the retreatment cases. So this was overall about the prevalence in the TB patients. When we look at the distribution of the kind of tobacco, again, there are some interesting things which come out over there. So as expected, as there is elsewhere in the country, smokeless tobacco use was much higher than smoking only or even dual use. So there were quite a few tobacco users who were having dual tobacco use. So they were using some smoking form as well as some smokeless form. So again, the distribution we can see over here is like significantly. One thing was there that though overall smokeless tobacco use was higher, and among females, the proportion of tobacco use itself was very low, which was 5%. If you see the type of tobacco use, almost 95% of the females were using smokeless tobacco. So here smoking was very little that we saw. In terms of age group, the distribution was evenly distributed in terms of the smoking versus smokeless. Again, if we come to the TB type, pulmonary versus extrapulmonary, the smokeless was a little on a higher side among extrapulmonary, whereas smoking was on a higher side among the pulmonary TB patients, as expected, I would say. And in terms of new and retreatment, there was not much difference in terms of their tobacco products as such. So looking at the outcomes, so what we did is that the intervention was brief advice, which was provided on a regular basis. The documentation which was required was as per the union guideline, which is the ABC, the Green Book. The documentation was required at the time of sputum follow-up. So this was the schedule of sputum follow-up. So for new patients, it was at 2, 4, 6 months, and for retreatment patients, it was at 3, 5, 8 months. And there was a documentation of the tobacco use done for every tobacco user that was involved in this study. So totally, if we see, there were 251 new patients and 126 retreatment patients to start with. There was some attrition, programmatic attrition that we saw, and totally at the end of 6 months, 196 of the new patients were retained in the TB program, and 87 of the 126 TB patients were retained by the TB program in the retreatment category. Out of this, if we see, the documentation rate gradually decreased from like 70s in to begin with, and then it dropped to 36 among the new patients, and similarly to around 30 in the retreatment patients. So overall, there was a drop that was seen in the documentation from the dot provider's end. So among those tobacco users who were followed up till the end, and among those whose documentation was maintained about their tobacco use, what we saw was that there were 26 tobacco users who have reported as stopping their tobacco treatment. So in terms of percentage, it is 32% of the new patients and 15% of the retreatment patients have reported that they stopped their tobacco use. Some have reported reduced use, and some have reported no change also in their tobacco use in spite of the intervention. So overall, if we see that overall there is roughly a 25% quit rate, if we can call it, that was seen after this intervention of 6 months in new patients and 8 months in retreatment patients. If we also look at the outcomes of the TB treatment, what we saw was that among the tobacco users who had stopped their tobacco use, their successful TB outcome rate was 100%. Whereas among those tobacco users who did not stop their tobacco use till the end of their TB treatment, the success rate of their TB treatment was 88%. So when we looked at the influencing factors, when we talked to the program implementers as such, like what was it that was influencing their implementation? What were the enablers? So these were the enablers that they have mentioned. So quickly, one is that the structure of the TB program itself, like I mentioned, it is quite structured. There are structured follow-ups which are there. There are sputum tests which are there, which give that opportunity for more interactions, more formal interactions with the patients and documentation opportunity as well. So second part which was mentioned by them was the training itself. So though they were talking about tobacco once in a while, or they knew the association of TB and tobacco, a formal training was really very important to them, not just for the knowledge part of it, but they also mentioned that that gave them the confidence and motivation to talk to people, to talk confidently about tobacco use, to advise their TB patients for quitting. And according to them, this was like something they were providing in addition to the regular TB treatment service. And that gave a good impression on their patients, that they are really caring for their patients. And of course, that supportive supervision is, as like everywhere, it is important in any program. So that played a role over here. In terms of challenges that were mentioned by the TB treatment providers, one is that the question they asked is, why do you call it brief advice when it is not really brief? So like theoretically, this brief advice is supposed to be 5 minutes or so. But what happens in reality is at field level, it is not 5 minutes only. So they initiate this discussion, they talk about it. Dr. Rana was mentioning about the rapport building over there. So that takes some time. And when during those conversations, the issue of tobacco comes up, the point of giving brief advice comes in, it's more than 5 minutes, which is theoretically expected. So they are saying that it is time consuming. It's not really brief as the name suggests. And that sometimes causes time constraints, because at some points there are too many patients coming in at a time, and then you do not get enough time to talk with each and everyone. So there are some missed opportunities that have been reported because of that. Also, there was that increased documentation which was added on during the intervention, which was mentioned as a hindrance by some of them. Patient confidentiality was stressed upon right from the beginning in this intervention, and that was one of the factors which had to be carefully looked at when they were in the setting of the clinic, where there were other patients. Sometimes there were relatives, and the patient did not want to talk about their tobacco use in front of relatives, or sometimes the relatives did not know that there was a tobacco product this patient was using. And so the issues of confidentiality had to be carefully handled, and they were handled, of course, but that was something which was challenging. One more thing which was mentioned is coping with the symptoms of nicotine withdrawal. So in spite of the training and in spite of the tips and tricks that were provided, this is something which is to be handled very carefully, because nicotine withdrawal is known to lead to slips, and that slip may lead to a relapse as well. So that is where these have to be handled, and then more training, more refreshers have to be conducted to equip the team for handling this. And the last one challenge, which was more at a cultural or a community level, was that normalization of tobacco use. So TB patients did not really see the link between tobacco and TB. They did not find the need or the importance of quitting their tobacco habit because they have TB. So that had, and it was like, it was everywhere. It was socially being used, and it was part of their life, and they did not see the importance. So that was a challenge, and it had to be overcome when implementing this. So these are just a few of the quotes that we got when we were talking. So it is covering basically the training part of it, this additional sense of pride which these TB providers were now getting in helping their patients about their tobacco use as well. So this was something which we saw all across in all the centers, wherein which showed us that this was easily acceptable to these people and they liked what was added onto it. So we come to the key takeaways or the conclusion of what this was. So one is that yes, it is feasible. Of course, we did it in a small setting. It was an NGO setting wherein we are not working in the government setup, but this NGO setup, which is part of the RNTCP at that time. So in that, it was feasible to add on this component of tobacco cessation, and it was providing benefits to the individual patients, not just in terms of their TB treatment outcomes, but overall in their general health scenario. It was beneficial to the patients, and of course, and also it was well accepted by the providers who were providing this treatment. The second part is about scaling up. Yes, we have reached a point where now it has been scaled up. It has been part of the system. There are documentation guidelines, there are reporting guidelines. It is being discussed in the collaborative meeting. So, but this implementation has to be strong enough. It has to be rigorous. It has to be uniform across everywhere, and it has to be taken more seriously than it is currently. And also looking at, like we have done this in the TB setting, tobacco cessation should be and could be integrated in other settings as well. So similar initiatives are required, similar integration is required. So like we are talking of integration of the TB program in different settings, there is also need for integration of the tobacco cessation activities or the intervention within these other settings like NCDs, the ANC, MCH program. And as a part of our activities, Life First program has initiated a few certain interventions in these different settings. We are documenting it, and hopefully we can come up with similar models which could be used by others also, like how or what is to be done to integrate these cessation activities in other settings as well. So this was the publication that I was referring to based on this particular intervention. So there are details in it that you would see. So thank you very much. And these are my coordinates. So just in case, thank you very much for that patient listening, and thank you for this opportunity.
Thank you, Dr. Himanshu. Dr. Rakesh, we are behind the schedule. Would you like to summarize the?
Yeah, I think the takeaway points are important, that in an urban NGO setting in India, the integration of tobacco cessation interventions into a framework of routine TB care was feasible, and that brought individual patient benefits and was acceptable to providers. And there's another important takeaway point, that it has to be integrated in other programs too, the tobacco cessation. So thanks a lot, Dr. Himanshu. And Dr. Sanchika, can you just ask everyone to just switch on their videos so that we can have a snapshot before we call Dr. Ashish? Or please switch on their videos so that we can have a good snapshot. So Dr. Rakesh Gupta from Jaipur is also with us.
We are joined now.
Yeah,
Thank you.
let us.
It was nice webinar.
Yeah. Dr. Rana, are you with us? I think Dr. Rana has gone for another meeting. Doesn't matter.
Hello, yes.
No, he's there. He's there.
Please switch on your video.
Okay, please.
Yeah.
Yes, please.
Done, sir.
Thank you. And it is really commendable that 100+ people are still with us. And Dr. Mr. Arun, can you call Dr. Ashish?
Thank you so much. Now our last presentation and the last speaker of the day is Dr. Ashish Chawla, who is a district TB officer from Ludhiana. He's MBBS from GMC Patiala, and he's MD chest and TB from GMC Patiala.
Is not working.
Hello. Yes. As regarding his work experience, he has worked in the armed forces as a medical officer 5 years and as well worked as PCMS officer for the last 25 years. District Tree officer since last 18 years and district AIDS control officer, district nodal officer, National Tobacco Control Program. He'll be speaking on the district experience in integration of tobacco cessation and TB management. So over to Dr. Ashish Chawla.
Thank you very much, sir, for those kind words, and good afternoon to all. So, though I have come here as a speaker, but it was great learning, listening to the stalwarts like Dr. Rana and Dr. Rajinder and Dr. Himanshu. Though our experience is not that rosy as is there in Himachal Pradesh, because the tobacco cessation that we have attempted in our district is falling short of by miles as compared to what is being done in Himachal. Knowing the tobacco cessation of something like 97% and linking them to tobacco cessation centers for more than 90 and getting a quit rates of more than 47%. Those kind of things are not done here because basically what I analyze is that sometimes our main focus is on different things like on the diagnostics of TB, on the drug sensitivity testing, on DBT. There's so many other avenues coming up. And even amongst the comorbidities, what I feel is that tobacco is kind of taking a back seat as compared to HIV or diabetes for that matter. Because once we analyze our data in Nikshay, we found that HIV testing and diabetes testing is above 95-96%. But sadly, tobacco, where we do not need to take any test like we do for HIV or for diabetes, it's just asking the patient whether he's using tobacco or not. But we are falling short in that, not more than 65-70%. So coming on to the presentation, I won't take much of time here because most of the things have already been discussed by my seniors, by my predecessors. So kindly move on. Next slide, please. So all the purpose and objectives have been highlighted. We know that tobacco is a great menace and it disturbs our figures as compared to once we talk of TB outcomes, lesser cure rate, lesser conversion, that all had been discussed, more relapse rates and lesser immunity because of cell-mediated immunity defects, mucociliary clearance gets affected. But one more thing that I would like to discuss, which has not been highlighted till now, is sometimes the diagnosis of TB also gets delayed. That's what we have felt once patient is a smoker. Because many a time the cough, dyspnea, or the other symptoms of suggestive of TB are attributed to the habit of smoking. So there is a delayed health-seeking behavior in the tobacco smokers because, as I told, they generally attribute it to their smoking habit and they do not want to come forward and get tested for TB. And once they come over to the microscopy centers or to the ROPDs, they have a fairly advanced disease. They are having dyspnea because of COPD, and they are having hemoptysis, and they are having bilateral extensive TB and cavitatory diseases. So from that point on, treating them also becomes very difficult because the disease is already fairly advanced. And even the post-treatment sequelae and complications, they always remain there, even if they get cured of TB, because of the destruction to the lung by dual menace of TB as well as the smoking. So that is one part. And many times patient lands up with the symptoms like hemoptysis. And since he's been smoking for last 20-30 years, the first diagnosis that comes to our mind is CLR. So, that is where our focus is. We keep on asking for, CTs and PET CTs, even to that extent. And later on, the patient turns out to be a case of TB. So that is also one thing that I wanted to highlight. That's our daily experience coming across, patients who are smoking and also having symptoms suggestive of TB. Next, please. So a national TB prevalence survey has been done from 2019 to 21. And even that survey confirms that amongst the comorbidities, smoking is a very important comorbidity as far as the incidence of TB is concerned. 853 smokers per lakh population had TB as compared to malnourishment and diabetes and alcohol use. Next, please. So this all has already been described that rate of mortality rates are very high amongst the tobacco users. And many times, what we also feel in our OPDs, as a patient, cigarette bidi peete ho, so he say कि no, cigarette bidi nahi kabhi pee, jarda kha lete hain. As if there's the impression in these people that chewing tobacco is much less harmful as compared to smoking. So even that kind of counseling needs to be done, that any form of tobacco is harmful, and especially if the patient is having TB and is on anti-TB treatment. Next, please. So this has already been described. This is the information that we captured as a very beautifully illustrated by Dr. Ravinder in his presentation, that we capture the information on TB treatment card, and from there it goes on to the Nikshay portal. But where it's not up to the mark, the history of smoking or the linking to sedation, or even the patient who report quitting after that brief advice is very dismal to say. Next, please. So next, please. So this already has been explained, 5 A's and 5 R's that are used for counseling if the patient is willing to quit or not willing to quit. Next, please. Next, please. So that is the status of tobacco control in my district. Another thing that I would highlight is like it was presented in Himachal Pradesh that they have comorbidity committees even up to the district level, and tobacco cessation centers right up to the TU levels or PHA or DMC levels. So that kind of thing is not there. We have a district tobacco cessation cell, but that is located in the psychiatry department of civil hospital, and they have a lot of patient having drug abuse, so they are having OST, OT clinic, and their counselors are most of the time busy in that, and tobacco kind of does not get that kind of importance that it really deserves. So we notified close to 10,000 patients last year, and we knew about the tobacco status of around 80%, and most of them were using smokeless tobacco, and very few were linked to sedation, and we do not have any data on how many actually quit the smoking habit or tobacco usage with the advice. Next, please. Next, please. So this is the report from district TB, I said, district tobacco cessation center. So 147 patients were counseled and as well as given pharmacotherapy for tobacco, and 119 tobacco users were referred to, because as we know, it's a bi-directional referral. So all tobacco users diagnosed with TB are referred to tobacco cessation center, are supposed to be referred, and all patient, general client, even if they are attending to tobacco cessation cell, so if they're having symptoms suggestive of TB, so they should be referred to microscopy center for the diagnosis of TB. So 119 of them were referred to chest and TB department for diagnosis of TB. Next, please. So very recently, we have started with the adult BCG vaccination. We are going to start, in fact, the training, that part is still going on. So even if you look at adult BCG vaccination, we have a certain inclusion criteria. Of course, it's more than 18 years, as the name suggests, it's adult BCG vaccination. So we are taking 6 categories in that. One is the history of TB disease in the last 5 years, or if they are close contacts of TB, like household contact of a index case is a pulmonary TB or a microbiological confirmed TB, or individuals above 60 years or diabetics, and also if there is a history of tobacco use in a patient, then he qualifies for, or the low BMI, malnutrition. So all these 6 categories of patient or the general population, they qualify for adult BCG vaccination, because we know the incidence of disease is higher in these individuals. Next, please. So thank you very much. That brings to the end of my presentation. It's not very lengthy and there's nothing much to show, but it was great learning, listening to all of you. And I hope that we'll be able to replicate the things that are not done here, but done in other states in our state also. Thank you very much. And thanks, Dr. Gupta, for giving me this opportunity. Thank you very much.
Thank you so much, Dr. Ashish. So nice presentation where you have given us how many people were patients were notified and but how the tobacco status was known for about almost 90%, but in the smoking 86 and in smokeless 335. Link to cessation 68. Yes, great job done. Thank you so much. And also for the study of the population and inclusion criteria. So feeling the shortage of time, I think Dr. Rakesh, we can quit the question answer session.
Yeah,
and,
Rajiv is with us.
Rajiv to
Rajiv is with us
vote of
for
thanks.
Rajiv is with us for vote of thanks, and if there are any questions also, 1 or 2 questions we can take.
It's already 5 o'clock.
Yes, Rajiv.
Thank you, sir. Thank you. And because we have very less time, so I request the delegates, in case you have any question, so just unmute yourself and ask question to directly the experts.
I have one question, Rajiv, from
Yes.
Dr. Gupta.
Yes, sir.
Doctor,
Please,
and
sir.
that's regarding his criteria for successful quitting.
Sir, we
What-
considered the 7-day PPA. So I
Okay.
mentioned that during the presentation, 7-day PPA was the outcome measure.
Right, which is less actually, because even if we consider it as a minimum, I think 30 days quitting should be the one which should be used. And I consider
Yeah.
perhaps that you may adopt that criteria hereafter.
Yes, we have
for the-
adopted it already.
All right, great. Thank you. Thank you very much. And I think you should not mix up the reduction in tobacco use with quitting, because then the data will not be valid data. So
Yeah,
consider
it
that
is
point also.
reported separately. It is not mixed. So it is
Okay.
reported separately. Yeah.
Fantastic. Okay.
Yeah.
Great presentation from you and Dr. Ravindra.
Thank you. Thank you.
And Dr. Ashish, I think. Yeah, great.
Thank you,
Thank
Dr. Rakesh, for your very valid comments.
Thank you.
I'm afraid we won't be able to take any more questions. So over to Rajiv for a vote of thanks, for formal vote.
Thank you. Thank you, sir. Thank you, Dr. Rakesh Gupta, for putting these questions. Okay, so thank you, sir. Thank you for giving this opportunity to propose vote of thanks. I, Rajiv Chaudhary, Project Coordinator at PGI Chandigarh. On behalf of Sipher, Eco India, and Resource Center for Tobacco Control, PGI Chandigarh, I extend my heartfelt gratitude to everyone gathered here. We are honored to hear from experts in the field and as well as a representative from various organizations who participated in this particular webinar. Thanks to Dr. K.S. Sachdeva, President and Chief Medical Officer for Mortality Diagnostic, and sir is a former DDG MOHFW who participated as a chief guest for this particular webinar. Special thanks to our esteemed guest of honor, Dr. Mira Aghi ma'am, a behavioral scientist and communication expert. Ma'am is a member of Haride Research Advisory Board for providing valuable insight on this topic. Thank you, ma'am. I also extend my gratitude to all the speakers, starting from Dr. Rana J. Singh, Director, Vital Strategy, Southeast Asia, Dr. Ravindra Kumar, State Program Officer, National Tuberculosis Elimination Program, Himachal Pradesh, Dr. Himanshu A. Gupta, Vice President, Health, Narottam Sekhsari Foundation, and Dr. Ashish Chawla, District TV Officer, Ludhiana. Their valuable contribution and insight on this critical issue has been really commendable. I believe we can all agree that it was a privilege to listen to these eminent speakers during today's webinars. Thank you, dear friends and extreme professionals. And this event is required a meticulous planning and attention to detail. I want to express my thanks to and congratulations to the organizing team, led by Dr. Rakesh Gupta, Mr. Arun Verma sir from Sipher, and Dr. Sanchita Gupta from Eco India for leaving no stone unturned in success of this important webinar. And thank you, and round of applause to all of you showing keen interest in this event. Without your participation, none of us would have come forth. So thank you all and have a nice day.
Thank you. Thank you. Bye-bye.
Thank you. Namaskar.
Thank you.
Namaskar all. Thank you.